Great. So, good morning, everyone. Let's start without wasting the time. So, thank you very much, everyone, on the Sunday in a big numbers. So, I would be glad. And as usual, I mean, every Sunday we are conducting the new mock test. So, not going much in detail. I am directly jumping on the questions. Later on, we can discuss the answers and explanations and some other queries related with data flow or any other things we'll discuss later, right? So those who are not interacting, just one humble request, you can make your mic mute so it won't disturb me. Few people are joining from OPD as well. I don't mind, but just make your mic mute. Thank you very much. So let's start with the questions. First questions in front of your screen, right? This is the screen. 16 years old boy present to his GP complaining of nosebleed and bleeding after brushing her teeth. He is unsure of how long this has been occurring, but decided to seek advice after having to continuously excuses himself for the lesson. On examination, you notice he has some skin bruise, a blood test show a prolonged bleeding time and activated partial thromboplastin in time. While platelet counts and prothrombin times are normal, what is the most likely diagnosis? Von Willebrand disease, liver disease, disseminated intravascular coagulation, congenital afibrinogenemia, and Glanzmann's thrombasthenia. So for every questions you have 5, 10, 15 seconds, think over it and post your answer in the chat box. Yeah, muted my mic. Yes, Dr. Rashmi Arun, how you explain this, Dr. Rashmi? So by you, the answer is one Willebrand disease. So let's discuss a little bit more in detail now. So what points favoring the one Willebrand disease? Start now.
Sir, actually, I forgot the explanation, but I knew that from the clinical picture that it mostly fits the von Willebrand disease, because this is not the clinical picture of liver disease or DIC or Glanzmann's thrombasthenia.
Okay. So
But
possibly you are trying to exclude the other reasons, right?
yeah,
And that,
exactly.
and probably other features as well. Fine. So
Yeah.
now, right. So let me ask you, what is a classical presentation of von Willebrand disease? If you do not have this scenario, what's the impression in your mind that how von Willebrand disease present? We'll go step by step.
Um,
How usually
Sorry, sir, if you
presentation? I
have
mean,
asked me, like I know that it is a defect in the coagulation pathway. It's the what do you say? It is a deficiency of von Willebrand's factor,
okay,
and it is a coagulation pathway problem. So,
okay. So,
and mainly in the coagulation pathway problem, the prothrombin time and APTT will be increased.
okay. So here
Um,
they are saying platelet counts normal. Platelet counts normal.
yeah,
Prothrombin times are
yeah,
also normal. So PT is
yeah,
normal. Platelet count in CBC, platelet count is normal. So what is abnormal? What is
yeah.
abnormal here? As per the scenario, abnormal is what? So
Prothrombin time and APTT. Uh,
yeah, so APTT is abnormal, means increased, right? And bleeding time,
yeah.
prolonged bleeding time. So bleeding time is prolonged. Can you explain why these twos are elevated and why these are normal? Why PT is normal? Why platelet is normal? And why these twos are
Platelet
abnormal?
platelet count will be abnormal only in diseases involving the uh, what do you say, the coagulation platelet defects or platelet functional defects, and um, like that.
Okay, fine. Fair enough. So there is a in one. So concluding your concept, one Willebrand usually have a normal platelet, right? That is what you mean to say?
Yes, yes, yes.
Okay, fine. Okay. And why the APTT is high? APTT high. What's the reason of APTT high? Why the bleeding is high? What's the reason of bleeding time is high?
Sorry, sir, I'm not able to tell the explanation. I just know that in coagulation pathway defects, the APT and APTT will be increased, but I don't know the explanation of that.
No problem. Just give me a 1 moment. I get a call from emergency room. 1 second. Huh? Yes, sir. હા બસ એનું કંઈક 5:15 જેવું થઈ કઈને એને જોઈએ જોઈએ. હવે એને 5 તો ભરી દીધા છે એટલે કે સાહેબ હવે તમે 5 સવા 5 ની વાત કરી દીધી કે જોઈ લો તમે એટલે કદાચ એને હા બસ 5 પ્લસ જે ભરે તો ભરાવડાવ that's it. ના 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 એટલે તમે યાર હવે બોસ કહેવો ને સાહેબ ડાયરેક્ટર એટલે હવે અલ્ટિમેટલી કહો. મને ખબર છે પણ હવે આપણે બે ડીલ કરતા હોય એટલે પછી હું તમને બાયપાસ ના કરું સાહેબ કોઈ દિવસ. આપણે હું દાપણ ના જાતે કરું. કઈ વાત કઈ વાત નહીં. કઈ વાત નહીં પતાવી દો ને હવે હા ઉપર જે આપણે ઓકે ઓકે થેન્ક યુ. હલો. Yes, anyone wants, Dr. Banish, you want to try why the bleeding time is high and why APTT is high?
So elevated APTT, sir, it's because von Willebrand factor deficiency destabilizes factor 8.
So von Willebrand factor it is in the plasma, right? So why APTT? What is a APTT? I mean, to do with the von Willebrand disease. What exactly von Willebrand factor does with the factor or which factor, especially the which factor? Because APTT will increase in factor 8 deficiency, 9 deficiency, 11, 12. I'll
Intrinsic
give.
pathway.
Yes, sir.
Intrinsic pathway.
Yes, intrinsic pathway. But in intrinsic pathway, there are four factors, 8, 9, 11, 12. I
11,
will come
12.
on that cascade that as well. So which factor exactly affected or all
Seven.
factors in intrinsic pathway will get affected?
Factor 8.
Factor 8.
So factor 8
Okay.
gets affected.
Okay. Factor 8. Wonderful. Factor 8 is affected. So what is the relation of the factor 8 with von Willebrand factor?
It's a coenzyme, cofactor for the formation of synthesis of
Cofactor,
factor.
wonderful. Cofactor, that's fine. Cofactor. So if the von Willebrand factor deficiency, I mean, it carries usually factor 8. So if it does not there, it may not carry 8. Coagulation will not happen. PTT will high, right? And what is the reason behind bleeding time is high? Why bleeding time is high? What is the importance of bleeding time? Bleeding time is high. Fine. Anyone wants to try, they can try. Huh? It's open discussion. This is absolutely learning platform. You never thought of such questions. So let me come to the clotting cascade, which is one of the most difficult, and I will make you most easiest from now. Probably couple of people who are in old coaching they have seen,
So
but still I
it's a
want to
clotting
mention.
factor. So deficiency of clotting factor will increase the bleeding time. Von Willebrand factor is a type of a clotting factor.
We need to see first clotting cascade. So when there is an internal injury, right? Intrinsic pathway activate and external injury, extrinsic pathway we studied in our medical school in first MBBS physiology in the blood. Extrinsic pathway, right? It's a factor 7, right? After factor 7, this is how I remember. It would be very, very easy now onwards for you. Factor 8, factor 9, factor 11, and factor 12. Means you are thinking, where is this number 10 gone, right? So this is an intrinsic pathway. This is extrinsic pathway. They both merge and it become a common pathway. So 7, 8, 9, 11, 12 means here 10. 5 plus 5 multiplied by 2 is 10. This is how I remember. This is in common pathway. This activate prothrombin to thrombin, that is factor 2. And this thrombin will activate fibrinogen to fibrin mesh. Factor, this is called 13. Another name is clot stabilizing factor. Clot stabilizing factor. Is that clear so far? Yes or no? At least tell me yes or no.
Yes, sir.
Very
Yes,
easy
sir.
now. Very, very easy now. 7, 8, 9, 11, 12. Right? Intrinsic pathway is monitored by APTT, activated partial thromboplastin time. Right? And extrinsic pathway is monitored by prothrombin time. Right? Now, this whenever there is a intrinsic pathway involvement, this is called as a hemophilia A, factor 8 deficiency. This is called hemophilia B. This is called as a hemophilia C. No need to mug up. So what factor deficient? This is one of the most commonest. Hemophilia A or hemophilia, right, is factor 8 deficiency. Hemophilia most common, 70-80% of the patient have this. They usually present, this is more in a male, number one. They present with a hemarthrosis. Hemarthrosis. Have you heard of this word hemarthrosis? Yes or no? Hemarthrosis, right?
Yes.
And in this patient, PTT is increased. So this is classical presentation that the boy presented with the right knee swelling, right? Erosion of the joint on blood workup showing normal platelet, normal PT, but APTT is high. What is the diagnosis? So this three word is absolutely important. Just three. So you can diagnose anything. If you remember this, you can answer 100 questions from this cascade. 100 question, believe me. So intrinsic pathway, you don't need to mug up. You just need PTT increase means there is something wrong in this four factor only. That's it. If the extrinsic pathway, something is wrong here. That's it. Right? And if the both PT and APPTT both increase, means something wrong in the common pathway. Is that clear? Yes or no? Right? This is the complete clotting cascade. So what happens? One Willebrand factor or one Willebrand factor or one Willebrand factor antigen which carries this factor. So in absence of this, right, it will not have the effective work of factor 8 and that is why PTT is increased, APTT is increased, right? So it's a cofactor. Somebody told it's a cofactor. So this is one thing by which we in ICU, this is the everyday job. PT increase, APTT is increased, heparin is given, what increase, right? So you have all complete. If you know this, then you can answer any questions, right? So now your homework, I'm giving you the homework. You need to know where heparin works, number one, where low molecular weight heparin works, where DOAC, direct oral anticoagulant works, where warfarin works. Anybody wants to try these questions? All questions? This all one cascade, all answer. One cascade, all answer. That's it. One cascade, all answer, right? So you need to go and read this. We will discuss this all in the next class because we have very important questions to discuss as well, right? So you must know because you are giving, this is clotting cascade, right? These all are the anticoagulant drugs. So they act like say warfarin, right? Which factors they inhibit amongst this pathway? Anybody knows if you give the warfarin as an anti factors is
Factor
inhibited.
7, sir. Factor 7. Warfarin
Factor
act on
7.
the extrinsic factor.
Yes, so factor 7. So along with the 7, 2, 7, 9, 10, right? So it mainly affect the factor 7. That is why PT and INR, we are monitoring those patients who are on warfarin. Isn't it? Yes or no? There are direct oral anticoagulant drug, oral anticoagulant drug XA. This is factor 10A, right?
Yes.
So direct oral anticoagulant drug, newer drug. So there are two drugs. Earlier, many years we used to use a comudin or warfarin, right? It's a oral anticoagulant. Still we are using, and there is a newer oral anticoagulant, or now latest name is DOAC, direct oral anticoagulant, right? So this drug, whenever there is a XA comes, it inhibits the XA activity, right? Let me give you the rivorabesan. This is XA, rivorabaxan, right? Apixaban, XA means 10A, ban. Dabigatran. Have you heard of this word? Yes or no?
Yes,
Danish,
sir.
have you heard of this
Yes,
word?
sir. Yes, sir.
All are the newer. They XA means 10A activity. This is how the name comes, 10A activity. So they inhibit the 10A. The biggest beauty of this direct oral anticoagulant drug, you don't need to monitor PT and INR. Don't need to monitor PT INR. So if the patients of pulmonary embolism comes to you, you give warfarin, you need to check PT INR and you need to monitor, right? If normal INR is 1 to 1.2 normal INR, 1.2. But those patients are on warfarin, you should keep between 2 to 3 INR, right? If it is less than 2, it is ineffective. And if it is more than 3, it is a risk of bleeding, right? So you need to balance between this. If your INR, hundreds of questions in DHA are there, INR is 5, what to do? INR is 10, what to do? INR is 15, what to do? So this is, you need to go and check it, right? INR 5 with no bleeding, how you manage, right? INR 10, no bleeding, how you manage? INR 10, no bleeding, how you manage? That's it. And INR 5 with bleeding, how you manage? Right? So these are the all high yield questions in the exam. So you must remember this, right? So now let's back come to the our STEM questions, right? This is what our question was, original question. So von Willebrand disease. Now let's, as Dr. Rashmi rightly said, it's a diagnosis of exclusion or she excluded. Now what happens if it is a liver disease? If somebody is thinking liver disease, why not liver disease? 10 reasons. Liver disease usually don't happen at 16 years of age. Number one, there is no history of alcoholism. There is no history of hepatitis B or C, which makes the cirrhosis of liver. Right? There is no other history of hepatotoxic drug. Right? There is no LFT mentioned, no protein, nothing mentioned. Right? There is no history suggestive of liver disease or no ultrasound. That's it. So these are the all factor against the liver disease. So liver disease is not there. Disseminated intravascular coagulation, DIC, disseminated intravascular coagulation, right? So let me tell you one more thing which is extremely important and basics as well. So whenever you are dealing with any bleeding in your OPD, IPD, emergency, this is common problem in day-to-day practice. So whenever any bleeding patient comes, there are three possibility. One possibility is it is a platelet bleeding. Another is a factor bleeding, and third is a vascular or anatomical. I'll give you the example. When there is a platelet bleeding and factor bleeding, any factor, clotting cascade, this all factors. So remember whole clotting cascade, extrinsic, intrinsic, and copper, what we discussed just now, right? So remember this pathway for factor. This is a primary hemostasis. This is secondary hemostasis. This is pattern, how patient comes to you in emergency or OPD. It is a mucosal bleeding, superficial bleeding. This is deep bleeding, deep tissue bleeding. This is extremely important. How patient present? Epistaxis, hematuria, increased menses, ecchymosis, patechi. This is what the presentation of classical platelet pattern, primary hemostasis. So whenever there is a bleeding, first things comes in the action is a platelet and then factor and then everything, right? Here, deep-seated bleeding. It's not superficial. Here, I told superficial. Here, the bleeding is deep-seated, usually, like intra-abdominal hemorrhage, intra-articular or hemophilia, intra-articular hemophilia, hemarthrosis, intracranial hemorrhage, excessive hemorrhage post-surgery or post-trauma. Are you getting me? Tell me yes or no.
Yes, sir.
Wonderful.
Yes, sir.
Wonderful. Wonderful. This is a pattern of factor. Pattern of factor. Vascular, because of directly vessel injury, right? Direct vessel injury or injury, right? or some atriovenous malformation, right, or some vascular problem. Here we see CBC, PT and APTT, how it differentiate. Fibrinogen as well. Fibrinogen as well. So here platelet problem, right? So usually platelet is low. If there is a platelet thrombocytopenia and bleeding, right? Bleeding because of thrombocytopenia, platelet is low. In that case, platelet, PT and APTT normal. Why? Because it has nothing to do with the factor. When there is a problem in the factor, CBC is normal. PT or APTT is increased as per the intrinsic or extrinsic pathway involved. And many a times fibrinogen gets also involved. So that gets lower, fibrinogen. Vascular problem, CBC is normal, PT and APTT is also normal. Something to do with the vessel. It's a local problem. Vascular. They have nothing to do with low platelet. They have nothing to do with the pressure. Is that clear? Yes or no so far? Tell me yes or no.
Yes, sir.
Yes, sir.
Right. Now let's go to the DIC, disseminated intravascular coagulation. Causes of DIC mainly infection, septicemia, sepsis, malignancy underlying, thrombophilia status, blah blah. Long list, just for your understanding. So when there is a disseminated intravascular coagulation happen, platelets are also come to form a clot, and along with the platelet, factors are also comes to form the platelet. So this is called as a consumptive coagulopathy. Consumptive coagulopathy. So when they utilize lots of platelet for the clot formation, disseminated means there are not at the one side, many site in the body. Disseminated means widespread. Disseminated intravascular coagulation. Disseminated intravascular coagulation, right? So there is a disseminated intravascular coagulation. So PT and right. So here platelet utilized. So platelet counts are low, factors are utilized, that is why PT, APTT both high, and fibrinogen gets low because everything get utilized, right? CB platelet plus factor, complete clotting cascade. So here the picture is low platelet, high PT, high APTT, low fibrinogen. This is not our case. This is not our case, right? Our case is what they are saying, right? Our case is saying platelets counts are normal. So platelet counts are normal means it is not a DIC. Prothrombin times are normal. It is not DIC because if it is a DIC, then increase PT, increase APTT, reduce platelet count, and reduce fibrinogen. Is that clear? Yes or no? Yes or no?
Yes,
Yes,
sir.
sir.
So here disseminated intravascular coagulation is gone. Congenital afibrinogenemia, it's nothing to do with the congenital afibrinogenemia. Right, 1 second. Sorry, I'm getting some call. I don't know. Emergency. Yeah. So congenital fibrinogenemia and Glanzmann's thrombocythemia is a platelet functions disorder. So what other your homework is to know the platelet. There are two problems. One is a qualitative problem. Qualitative quality. There is a problem in the quality. So two main problem in the quality. One is aggregation. There is a problem in aggregation, and another is in the adhesion. Right? Adhesion is adhesion and aggregation. Adhesion is Bernard-Soley syndrome, and this is Glanzmann's thrombocythemia, where platelet counts are normal. So when there is a platelet functions disorder, the numbers are normal. Patient has 150,000 platelet, but still is bleeding. There could be a platelet functions disorder, not a number disorder. So when there is a quality problem, so what is the normal quality of platelet? This is endothelium, right? When there is an injury to the endothelium, what happens? The platelet comes together. Number one, first thing is a aggregation, right? And another is adhesion. Along with the von Willebrand factor, they adhere and make a clot, right? So problem in the aggregation or adhesion, the name is Bernard-Scholier syndrome and Glanzmann's thrombocythemia, where the platelet counts at 150,000. So it's a quality problem. And another problem is a quantitative problem. Quantitative problem. So quantitative problem means what? Platelet count should be 150 to 450. So if platelet numbers are low or platelet numbers are less, they gets the bleeding. So this is called as a quantitative problem. Example, ITP, right? Dengue, malarial low platelet, right? Then leukemia, lymphoma, aplastic anemia, where numbers are low, platelet counts are low. If you check the CBC, all the things in all condition, platelets are low. Here in Glanzmann's and Bernard-Scholier and other platelet functions disorder, platelets are absolutely normal, within normal limit, right? So here, this Glanzmann's thrombocythemia is a platelet functions disorder where PT bleeding, PTT is not high. PTT is not high. So that also exclude the things. Dr. Reshmi, you get my point, right? What I'm trying to explain, right? So
Yes, definitely, doctor.
this is how we have to solve each and every MCQ. We don't need to mug up. We don't need to mug up any questions, right? We need to exclude each and every questions. And if you practice this, so by solving this problem, we solve almost 10, 20 questions in one question. Almost now. You get the clarity. Extrinsic pathway, intrinsic pathway, where drug, where act, right? Where warfare enact, where direct oral anticoagulant works. Still, you need to brush up once again, right? Just to make it more better impression, right? Anyone knows what are the types of the von Willebrand? Dr. Rashmi, if I can ask you, because you started these questions. So now this is von Willebrand disease, right? The key features, remember this too, if you want to
Yeah.
quickly review. Patient bleeding with increased PT and increased APTT. This is just like a pathognomonic thing for you to remember. Von Willebrand disease. That's it, right? Is there any type of the von Willebrand
Okay.
disease? Do you remember some type of von
Sir, there are
Willebrand
three
disease?
types.
Okay, so there are three types. So can you
The
tell
type
me
No,
what
one,
sir.
are
type
the,
two,
I
and
don't
type
remember now.
fair enough. Anybody, Dr. Benish, if you remember, what are the three types?
Sir, there are three types: type 1, type 2, and type 3. Type 1
Okay,
is the
type
most
1.
common, and it is autosomal dominant. Type 2 is autosomal dominant, and type 3 is autosomal recessive.
Okay,
Sir, and in
fine.
type 3, the most common presentation is epistaxis and menorrhagia, and type 3 is also present in early age group.
Okay.
And in
And
type
last but
3, sir, desmopressin is not effective.
okay,
In type
here
1, it is effective.
desmopressin is not effective. How the and type 1 is effective. So excellent explanation. I'm very impressed. So desmopressin, how desmopressin help in this patient? Can you tell me a little bit if you don't know? So if
Release
you have a patient,
subendothelial stores of factor 8.
excellent. Factor 8 as well as von Willebrand factor as well,
Yes, sir.
because
Sir,
it's a
and if
von
it is
Willebrand.
not effective, we can use factor 8 replacement.
Excellent. So I think Dr. Benis is very well versed with the hematology. So variants of von Willebrand disease, they ask in the exam. This is everything from past papers, recall, so don't ignore it. This is absolutely just I'm trying to make absolute take home message, because to compile this literature you need a lot of books to open. So I did it for you, and this is absolute take home message. So there are two type of von Willebrand disease, Dr. Benis, as you rightly told. One is a inherited and another is a acquired, right? Inherited has a
Yes.
three pattern, mainly what we seen in a clinical practice. As you rightly mentioned, type 1, type 2, and type 3. Type 3 is the most dangerous, but fortunately only 3% incidence or less than 5%, right? Second is second most common. So third is third, first is first, second is second, like that. So this is the most commonest one, which is a milder form, overall milder form, right? You can say this is moderate and this is severe. So severe one fortunately is just 3%. So it's a good thing. Thank God. Right? As Dr. Benis rightly said, it is autosomal dominant inheritance. This is autosomal dominant inheritance. This is autosomal recessive inheritance. How they present? Type 1, most common, 85%. I means 8 or 9 out of 10, they have a type 1. Mild to moderate deficiency of von Willebrand factor and factor 8. See, right? That is why
Mhm.
PT is increased, PTT, sorry, right? In von Willebrand factor 8, right? So mild to moderate deficiency of von Willebrand factor and factor 8, right? So that is the thing. We'll see the treatment as well. Second type is what? Is a dysfunctional von Willebrand factor. Dysfunctional von Willebrand. So this is only von Willebrand factor dysfunctions, right? So what you see in clinical practice, sometimes you just see increased bleeding time. PTT is also many a times normal, especially in type 2, because it has nothing to do with deficiency. Type 2 especially, right? Just there is a problem or dysfunctions, or this is a qualitative problem. Dysfunctional. Function is not normal of von Willebrand factor. And this is the worst one. Complete absence of von Willebrand factor and factor 8. This is the worst one, right? This is the worst one. So these are the things, right? And this is congenital, right? Inherited, right? So this is inherited. And some patient may acquire during their lifetime. That is called acquired von Willebrand disease. By and large, the pathology is same. But what condition can cause the acquired von Willebrand disease is lymphoproliferative, myeloproliferative, lymphomas, autoimmune disease, right? Hypothyroidism, right? And few drugs as well, this causing von Willebrand, because they directly act on the von Willebrand factor. So this is what the basic classification. Dr. Ben, is you clear, right? So
Yeah.
there is a congenital and acquired, and in congenital there are three varieties. Now we'll jump to the treatment. How one mild, moderate, severe we gonna treat this patient, right? Because this is high yield question in exam. So history, how you diagnose it is also very important, right? And how you make a suspicious. It's a diagnosis of high suspicious. Until and unless you are suspicious, you never diagnose. And let me tell you, this is one of the most commonest congenital inherited bleeding disorder. Most common. If they ask you in the exam, most common inherited bleeding disorder is a von Willebrand disease, right? So what is the history? Recurrent episode of bleeding since childhood. So it starts in the childhood, right? They are usually congenital, right? And they many a time they have positive family history. Now let's come to the stem of the lab. Bleeding time, it is high, as it is also high in our scenario. Bleeding time is high. Normal or increased PTT, normal, especially von Willebrand factor type 2, you may get normal, but there is usually high APTT, that is also there. Why? Prolonged, because this is a cofactor, factor 8 deficiency. Here, see, platelet and PTs are normal because they have nothing to do with the extrinsic pathway and platelet, right? Factor 8 is low, absolutely. Why? Yeah, that is why PTT is high. Von Willebrand factor is also low. And this is another exam questions. Which is the best test to diagnose the von Willebrand disease, doctor? Benis, which is the best test? If you want to diagnose best test, which is the best test? So best test,
The
two test. Directly you,
ristocetin cofactor.
yeah, one Willebrand factor antigen activity in the plasma if you measure, right? This is the best test. And
Yeah.
also this test, ristocin cofactor assay. Remember, ristocin cofactor assay. What does they do? Failure of platelet aggregation or restocin cofactor level less than 30, right? And further qualitative assessment by collagen binding assay, though this is little advanced test, but you can remember restocin cofactor assay and activity in the plasma, activity, how much von Willebrand factor is there in plasma, like percentage, like hemoglobin is 13 to 15 normal example. So quantity you are measuring here, also you can measure the quantity of von Willebrand factor in a normal individual as per the age and sex. If it is less, again that diagnose that okay, they have a less von Willebrand factor, so it's a von Willebrand disease. That's all. So this is what the thing is. And last but not the least, the treatment part is absolutely very important. As rightly told by Dr. Banish, desmopressin stimulate the von Willebrand factor release from the endothelial cell. So what happens? This is a vessel. This is a endothelium, right? This is a endothelium, right? So this von Willebrand factor is present in a vascular endothelium. So when there is a vascular endothelial injury, von Willebrand factor will release and it makes the clot to happen. That what does it mean? If there is a problem in von Willebrand disease, clot will not happen, means there is a more bleeding. So they present with the bleeding diathesis. Is that clear? Yes or no? Tell me yes or no.
Yes, sir.
Right? So von Willebrand factor, right? So either you have two choice. Either you give ready-made von Willebrand factor, intravenous von Willebrand factor, like platelet counts are low and patient bleeding, you give PRC, platelet rich concentration or single donor platelet. This is how we give in the clinic. If hemoglobin is 4 gram, we give directly PCV. So if you have less von Willebrand, you directly give intravenous von Willebrand factor. But if not available in urgency, desmopressin, what it do? It releases the von Willebrand factor from the endothelium and try to increase the level of von Willebrand factor, which makes the clot to happen in a bleeding patient. So von Willebrand factor, if not there, means there is a bleeding. That's it. So desmopressin is the drug directly act at this level, right? Directly at the endothelial level or cell. So best initial treatment for mild to moderate or type 1 or 2 is the desmopressin. Not effective for 3 as rightly told by doctor. Not effective. And this type 3, then what to do for type 3? So type 3, concentrate of von Willebrand factor and factor 8. Have you heard of this word cryoprecipitate? Anyone heard of this word cryoprecipitate?
Yes, sir. Yes, sir.
Yes, sir.
Right? Cryoprecipitate, fresh frozen plasma, packed cell volume, right?
Mm.
These are the blood products, right? These are the blood products. So this cryoprecipitate is a good source of von Willebrand factor and factor 8. So in emergency, if von Willebrand, known case of von Willebrand patient comes with the bleeding, in emergency you can order 4 or 6 cryoprecipitate, stat give. It increases the level of bond. FFP is not a good source of von Willebrand and factor 8. And PCV is absolutely not, obviously, right? But if this is not available, say for, then you can give FFP, whatever the small amount of these things are there in the fresh frozen plasma. It may helpful, but if they ask you in the exam which one is the best, then cryoprecipitate is the best. So concentrate the containing von Willebrand factor and factor it indicates severe bleeding, blah blah blah. Right. So when DDAVP is not effective, you can use this. And there are other drugs as well. Antifibrinolytic we usually give in the bleeding patients. Right. Tranexamic acid is very most common popular brand. Have you heard of this name, tranexamic acid?
Yes.
Yes, sir.
So we give in the patient, right? Excessive menses, we give, right? Excessive
Mm.
this bleeding patients, we give usually the tranexamic acid, right? So this is how we diagnose. So I think I take you to the whole journey of von Willebrand disease in detail, right? Along with this, so this is how they present. This is how bleeding, primary, secondary, and vascular bleeding happens. This is how the clotting cascade happens, right? And this is how they are classified, congenital and acquired. This is how they present history and diagnosis, and this is how they get treated. Is that clear?
Yes, sir.
Yes, sir.
Dr. Reshmi, is that clear now?
Yes, sir, it is clear.
Wonderful. So I wish once again you go and read it from the book, either Master the Board or any book, or it's all available on our website in hematology sections as well. It's all from there. Second questions in front of your screen. These all are the high yield and tricky questions where you get confused. Or I have seen that for most of the students, they are confused in such questions, right? That is why I posted these questions. Hemoglobin electrophoresis done for a young adult male patient whose HbA is 58%, HbS is a 35%, HbA2 is a 2%, HbF is 5%. What is the most likely diagnosis? Take your time, 10 seconds, 15 seconds, max 30 seconds. Try to post your answer in the chat box. Try to utilize your complete brain, what they are trying to say. And those who will not able to answer these questions, those who cannot know the normal range of the hemoglobin electrophoresis. If you know the normal range of hemoglobin electrophoresis, probably your job is bit easy. Yes. So I did not get any answer so far out of 35 doctors in the group. Right now we are 35 people in this class. Yeah, if I get 5, 10 questions, then I can able to discuss well. So I'm waiting. I'm not in hurry at all.
So it is a sickle cell trait.
Yeah, I've seen your answer. So let's see how other people, because we need to understand the concept. Just post the answer, doctors. Consider if this same question comes in your DHA had MOH, how you gonna respond it? You need to post something, some answer, at least some answer. Forget about right or wrong. We'll discuss. But first, you don't keep blank in the exam. I strongly recommend don't give blank in the exam. Yes, Dr. Reshmi, what's your answer here?
Sir, I wrote a sickle cell anemia, but frankly, I'm not sure about the hemoglobin electrophoresis values.
Okay,
I'm
fine, fair enough.
still.
Fine. So this is probably the guess, right? If let's see how the
Yeah,
guess
I'm
comes.
confused between I was confused between whether it is the trait and anemia, but since I don't know the values of correct values of the normal electrophoresis, then
Fine. Hopefully they will give. Hopefully they will give. But if they don't give, right? If now I will make your job bit easy. Everyone's job easy. Hemoglobin A normal value is 95 to 98% normal. HbA2 is say less than 2.5%. HbF is less than 1% and HbS is 0%. Now you try. Anybody. This is normal value. Right? Now you compare all the things. I probably not able to compare in exam. Right? So you compare and now you think over it, what it could be. This is normal range. Yes, Dr. Nasrin, any comment? Dr. Abdul Aziz, any comment?
Hello, sir.
Yes, sir.
Yes, sir. I think the diagnosis is sickle cell trait, sir.
Sickle cell trait. Okay, so
Trait,
now
yes, sir.
first of all, we go by one. First of all, tell the things how we differentiate sickle cell, right? Sickle cell trait and sickle cell disease, right? Or sickle cell anemia. Sickle cell anemia. And this is sickle trait. How we gonna differentiate? Is there any demarcation line between this to differentiate? That okay, sir, this is trait, this is disease or anemia. Sickle cell disease is basically anemia. Sickle cell disease is equal to sickle cell anemia. So don't get confused. And trait is a minor problem. So how you differentiate? I mean, is there any demarcation line? Because you should know, na. My argument is that why it is not sickle cell anemia? Why it is straight? HbS is a 35%.
Yes, sir.
Yeah. So what?
HBS of 35%.
Sir, I think it is sickle cell anemia.
Okay. So why sickle cell anemia? Why not sickle cell trait?
Because
Yeah.
I don't know whether that's right, but this has abnormal HbS value. And
Yeah. So it can be abnormal in all the things, doctor.
so the main difference between sickle cell trait is sickle cell trait will not be having, I mean, a disease actually. They
Yeah,
will
but
be
how?
having
So
one normal gene.
yeah. So
HbA is
say for
58%. That is it.
short question, right? If I can say HB is a 50% and HbS is a 30%. HbS means sickle hemoglobin is 30%. What you call this disease or this disease? This is also trait. This is also trait. So now listen me. Normal value, as I already told you, this is up to 95 to 98%. You must know it. A is usually less than 2.5 or sometime 3, not very high. This is less than 1 to 2%. And HbS is 0, means no, 0%. There is no sickle in the blood, right? So this is a normal hemoglobin electrophoresis finding, right? So this is called as the adult hemoglobin. This is minor adult. This is fetal, and this is a sickle. So sickle is absolutely 0. Means there are mainly 3 hemoglobin A, A2, and F in a normal individual, and we are talking about the adult male, female. That's it, not pediatric age group. Little story about this. When baby is in uterus, hemoglobin, fetal hemoglobin is main. That is why the name comes fetal hemoglobin. After birth, once the baby gets birth, this chain, fetal to adult, will start gradually, and they will change absolutely after 6 to 9 months of age. This fetal, right, hemoglobin will convert into adult hemoglobin. This is normal physiology. 6 to 9 months, this chain naturally supposed to convert from HbF to HbA. When this problem in the conversion, and instead of A, HbF persistent beyond the age of 1 year, it is called as a thalassemia major. Simple. We'll see in this chart. This chart is absolutely self-explanatory. So far clear, Dr. Rashmi?
Yes, sir.
There are 4 entities. This is normal. Now we are expert of this normal. We know now what is normal.
Yes, sir.
Thalassemia minor, thalassemia major, sickle cell trait, and sickle cell disease. And another entity is a sickle thel, combination of both sickle and thel. We'll see all 5 entity in a very simpler way, so there is no confusion. When there is a problem in minor, thalassemia minor, so there are a lot more things to tell to you. In hemoglobin, there are 2 words, hem and globin. This globin, 2 alpha chain and 2 beta chain. In 2 alpha chain, there are 4 LA on the chromosome, 4 LA on the chromosome, and here mainly 2 LA on the chromosome. We'll discuss. So when there is a problem in alpha chain, it is called alpha thalassemia. When there is a problem, any problem, production problem, mutation problem, genetic problem, beta chain, it is called as a beta thalassemia. Simple, right? It has nothing to do with the heme. It's a globin is a protein. Globin is a protein, right? So this is a chain, right? So when the globin has a 2 alpha and 2 beta chain, if problem in alpha chain, it is called alpha thalassemia. If it is problem in beta chain, it is called as beta thalassemia. This is the basic thing, right? Now, when there is a right? So what happens in a minor? Only the A2 is at problem. A2 is at problem. A2 instead of 2.5, it may go up to 5, max 10%. Rest of the things, this is okay. This is also okay. HBS is 0. So what is the problem? Whenever you are diagnosing or whenever you are giving the answer in the exam for thalassemia trait, there is just mild elevation of A2. If you calculate this plus this plus this, total 100%. You can't have more than 100%. No? So say for example, this is 10%. Maybe this is, I can say 85%. So 85, right? 85% or 90%. So this is less than 1%, less than 1% or 0, nothing. So total 100%. So just minor thalassemia minor is a problem of minor hemoglobin. Major, I already told you, there is a problem in fetal hemoglobin. Persistence of hemoglobin F beyond the age of 9 months, there is a more than 90 to 95% of the hemoglobin in adult is a fetal, that is called as a thalassemia major. A2 is okay, A is okay, no hemoglobin S. So in minor, A2 problem, in major thalassemia, F problem. Comes to the sickle cell trait. Simple definition. Normally it is absent. Normally it is 0%, right? But when there is a HBS comes in the picture, so it comes on the percentage. So 10% to 40%, it is straight. Anything more than 40%, up to 95% or close to 100 RBC, it is a very severe condition. But anything more than 40% is a sickle cell. In our scenario, there is a 35%, right? So it is a sickle cell trait. In this answer, here sickle, normal it is absent, thalassemia absent, and normal individual there is no HBS, means sickle hemoglobin. Normal shape of the RBC is a dumbbell shape, and sickle cell anemia, it's a sickle shape. And that prones, that breaks the I can say flexibility of the RBC inside the vessel, and they get easily hemolysis. We'll discuss that as well. We have one questions of sickle cell, right? So this is primary pathology, right? It's inherited. Once you have sickle, it will be lifelong sickle. You cannot change from sickle to dumbbell normally by any drug. No drug is available in this world which can make sickle to normal. Only curative treatment option so far is a bone marrow transplant. Just for your knowledge, right? So here this is increased up to 40%, means all three is a 60%. If this in a sickle cell disease, if it is a 70% of HBS, means all these three is a 30%. That's it. Total 100%. Total of all is 100%. Right? So this is how. So here in minor, A2 problem, major F problem, trait, just you need to see the concentration, and here 40 or 40, less than 40, more than 40. That's it. And what's the problem? Last, sickle and thal, both combination. So what happens in sickle thal? How the picture is? So there is a component of thalassemia, means A2 is little also increase, and there is little HBS is increased, say for 10%. This is also 10%. So normally it's up to 2.5%, as I told you, and this is 0% normally. So instead of 2.5, it is 10, and instead of 0, it is 10. It is sickle thal, combination of sickle plus thalassemia minor. It's a sickle thal. That's it. So this is what the explanation from my side. I try to make it more simplified. Any questions, Dr. Reshmi here?
No, sir, it's clear.
Benish.
So clear.
Wonderful. So this is simplest form. So if you remember the normal one, I would be glad and happy, right? If you don't remember, this is the simple. This is one of the most basic of the basic thing I told you, right? So this is how. You don't need to do a lot of PhD on thalassemia and sickle. We are not giving hematologist exam. We are giving GP exam. But for the concept clarity, you must know that, okay, fine. This is how it works. right? So because they can ask you, because if I just discuss sickle, then they may ask you minor, they may ask you major, they may ask you sickle cell. So that is why given you all the five tentative possibility. Other hemoglobinopathies are also there, but not going much in detail. This is what they routinely ask clinically, right? So this is what the thing. So let's go to the scenario, right? So here HBS is supposed to be absent. So HB, see what is first you need to see what is abnormal. So HBS is in normal individual, it is absent. It is 35, so less than 40%. So number one, A2 is less than 2.5, reasonable. This is little high, but it's fine. And this is low instead of 90. Why low? Because HBS is high. So in the blood, there are matured red blood cell, which is a concave shape, dumbbell shape, sorry. And when you see the peripheral smear or do sickling test, you see the sickle, right? So this is the morphology. You see under microscope, morphology, right? So in emergency room, if you are polydactyl and patient breathlessness and patient has a history of thalassemia, oh sorry, sickle, right? So just do the peripheral smear, CBC and peripheral smear. If you do, you can see lots of sickle cell in the peripheral smear, lots of sickle cell in the peripheral smear, right? And patient is not diagnosed, you can go for the hemoglobin electrophoresis and confirm whether it is a trait, whether it is a confirm, whether it is a disease, or how much is the percent. So higher the percentage of HBS, higher the event of sickling. So what's the main treatment? You need to reduce the sickling. If your HBS is 70%, your goal is to ideally get zero. But if you get 60, 40, 50, 10, lesser the hemoglobin S, lesser the complication. Simple and sober, right? So you need to reduce the sickling. You need to number of sickle in the blood or plasma while you are dealing with the sickle disease, and that is called sickle crisis. Have you heard of this word sickle crisis or not heard?
Yes.
Yes.
Yes, sir.
So, yeah. So now tell me, Dr. Benis, how we treat sickle cell trait and sickle cell disease head to head comparison. So this is a sickle cell
Sir, in
trait. So
sickle
now
cell,
how what you do?
yes.
Yes.
Sir, in sickle cell disease, sir, we will, sir, first of all, we will begin with the oxygen therapy.
O- Oxygen
If there is
therapy.
fever or
Why you want to give oxygen?
so hydration, we will also give, and analgesia we will also give. And then if there is fever or the WBCs are increased, then antibiotics like ceftriaxone, levofloxacin can be
Okay,
given.
sickle cell disease, say for example, sickle cell disease with pain crisis comes to the emergency, right? Severe pain, pain score is also there, 9 out
Yes,
of
sir.
10 pain score. Patient comes with a polydactyl, lots of hand and finger pain, comes to emergency in his known case of sickle cell anemia or disease. What is the first treatment you give to this patient?
So folic acid replacement or
So
hydroxyurea.
I'm writing your answer, huh? Just for discussion. Folic acid and hydroxyurea. So now you tell me how the hydroxyurea and folic acid will help in reducing the
So
pain or pain
hydroxy
crisis.
so
So first of
hydroxyurea will increase hemoglobin F.
fine. So first of all, it's a absolute wrong concept. Hydroxyurea has no role in emergency. Write down in bold letter in your notebook. No role in emergency room. It is not absolutely drug used for treatment. This drug is used for the prophylaxis
Okay, sir.
or the prevention. So patient has a sickle cell pain crisis, right? In 2000, right? November, December
Yes,
to
sir.
December, January he has a pain crisis. So he has a lot of pain crisis because of sickle. You want to prevent this. You need to do something so from this to this attack will not happen. Where the hydroxyurea comes in the picture. It is not in the treatment of pain crisis. While patient has 9 out of 10 pain, hydroxyurea has absolutely no role. Is that clear? Yes or no? right?
Yes, sir.
Hello,
Yes, sir.
Benish.
Yes, sir. Yes, sir.
Because say example, you had given the hydroxyurea. Do you think it will increase HbF in just half an hour?
No,
Never,
sir.
never, right? So this is mainly wonder drug. I used in all of my patients for last 20 years, hydroxyurea, but that is not in the brain crisis. That is for the prevention. So when patient is absolutely fine, asymptomatic, walking, talking, going to school, job, enjoying, I will give hydroxyurea. I don't want that he will present with pain crisis in emergency room. What is the biggest advantage? This is all exam question. Huh? Which drug? What action? So main HbF, fetal hemoglobin, HbF, right? Is this HbF fetal hemoglobin, say for sorry, HbS sickle hemoglobin, say for example, is 80% or 70%. So once you give the hydroxyurea, it will not reduce the HbS. Let me tell you, it will increase the HbF or fetal hemoglobin, and that is protective. That is protective against HbS. That's it. So if you increase the HbS, right, it reduces the intensity of the sickling, right? So it has nothing to do with the hemoglobin S. It will increase the hemoglobin F, fetal hemoglobin. That is protective in sickle cell. Is that clear? Yes or no? So this is mainly the prevention point of view, right? Not the
Stress.
treatment point of view. So here the treatment, any sickle cell disease now onwards comes in your emergency, you should not bypass the hydration. Number one treatment. Hydration reduces the sickling. Hydration reduces the sickling. You want to reduce the sickling in, right? Even blood transfusion is later. First and foremost thing is to give good amount of IV fluid or wonderful hydration to the patient in sickle cell disease, and then you can give the oxygen because of this is hemolytic anemia. RBCs are low, hemoglobin may be 5, 6, 7, tissue perfusion. So what are the precipitating factor of sickle? In which condition the sickling will increase? Benis, what are the condition where
Hypoxia.
sickling? Excellent, wonderful. One is hypoxia. Second is a dehydration.
Yes.
Dehydration. Third is a infection. So these are the three very most important things in the clinical practice. So even managing hydroxyurea is, I mean, hypoxia is little difficult even at sometime in emergency. Hydration, excellent, important. Tell the patient, give a good hydration. That's it, right? So hydrogen,
Mhm.
oxygen. Third thing is patient is usually anemic, especially when they have aplastic crisis or hemolytic
Yes, sir.
crisis. You need to increase the hemoglobin as well. So you give the blood transfusion or pack cell volume. If patient has an increased WBC count or leukocytosis or history of fever or history of splenectomy, give
Stress.
prophylactic as well as therapeutic antibiotic. Right? This is what the standard treatment is. And last but not the least, supplementation of folic acid lifelong, hydroxyurea for prevention, and only curative options across the globe is bone marrow transplant. That's it. Because this is inherited genetic disorder. You cannot change the gene. You cannot change the gene by hydroxyurea, by blood transfusion, by oxygen, by hydrogen, by folic acid, by calcium, by vitamin, nothing. Only bone marrow transplant, hematopoietic stem cell transplant can change the gene, right? By hematopoietic stem cell regeneration and differentiation. And then this patient will get cured. So treatment of thalassemia major and treatment of sickle cell disease, only available treatment right now in the world is bone marrow transplant. Another name is a stem cell transplant. They are the same thing. Benis, is that clear?
Yes, sir.
So these all questions in exam. So you don't ignore. Anyone cannot ignore. This is hemoglobin electrophoresis. So I told you already, right? Normal, thal trait, thal minor, what HbA, A2 and F, how it increases. So it shows in the band form. So by and large the same story, right? And this is what the thing is. I already explained you and told you This is a basic structure of RBC, 2 alpha and 2 beta chain. If it is alpha problem, alpha thalassemia, beta problem, beta thalassemia. And this is little cascade of the complication of transfusion. So we'll see later on, right? So this is what the thing is. So begin with the hydrogen, oxygen and analgesia, folic acid supplementation. Now, can anyone tell me which vaccines can be given to the patient with sickle cell disease or somebody has autosplenectomy or splenectomized patient? There is an exam question. Which vaccines are given in this case?
Pneumococcal vaccine. Pneumococcal vaccine.
I need three vaccine name. One is a pneumococcal. Second one,
Haemophilus influenza vaccine.
excellent. HIB, right? Hemophilus
Yeah.
influenza type
Yeah,
B.
influenza vaccine. Yeah.
And third one, excellent. Meningo. So pneumococcal, meningococcal, and HIB. This is recently asked exam in the DHA. So which vaccines are given prior to splenectomy, right? Because when you remove the spleen, the risk of the infection in splenectomized patients is very high, right? So you give this vaccine, right? That reduces the mortality probably, right? By acquiring the infections. So now instead of spleen, this vaccine will act as a fighter in our body, right? So this all three vaccines is absolutely any not spleen this sickle, any patient, any indication when the splenectomy is done, either leukemia, lymphoma, massive splenomegaly, tropical splenomegaly, right, or any other storage disorder, or because of any reason the spleen is removed, right? Or ITP, one of the treatment is splenectomy. So when the splenectomy do, in plan case you give 1 to 2 weeks before, and in emergency case after splenectomy you should give after 2 weeks this all vaccine, mandatory. Is that clear? Yes or no?
Yes, sir.
Third
Yes,
questions
sir.
in front. Third questions in front of your screen. 56 years old man comes to the emergency department because of progressive worsening shortness of breath and fever for 2 days. Get out of hematology. It's over now. Now it's respiratory. He also have a non-productive cough. He does not have a chest pain or headache. He has a chronic myeloid leukemia and a bone marrow transplant 3 months ago. His current medication includes busulfan, mycophenolate, tacrolimus, and methylprednisolone. His temperature is 38.1/100.6 Fahrenheit. Pulse is 103, respiratory rate is 26, BP is 130/70, pulse oximeter on room air is 91%. Pulmonary examination shows diffuse crackle. The spleen tips is palpated 4 centimeter below the left costal margin, and laboratory shows this. So this is the laboratory. I'll read for you. HB 10.3, hemoglobin, total WBC or leukocyte count is 4,400 per cubic millimeter. Platelet is 160,000. Glucose is 78. Creatinine is 2.1. D dimer is 96. Normal is less than 250, so looks normal. PP61 antigen is positive. Galactomannan is negative. Urinalysis is normal. Chest X-ray showed diffuse bilateral interstitial infiltrate. ECG shows sinus tachycardia. Which of the following is the most appropriate pharmacological therapy? So you can answer without, and it looks difficult, sir, what to answer. Then these are the therapy: levofloxacin, valganciclovir, acyclovir, heparin, ganciclovir, azithromycin. These are the name of the drug, right? And this is the scenario. Think over it 30 seconds. Not very difficult exam question, but little tricky, little tricky. So those who do not know, first time joining my class or listening this, I always give the triad, any MCQ, you must know the diagnosis. So in this case, we don't know the diagnosis. So first you need to make a diagnosis or possible diagnosis or differential diagnosis. Then you can ask which treatment is appropriate for this patient, right? So they are directly asking the treatment, what you will give to this patient. But before that, we need to know what is this, what with what we are dealing with. So take your time now. This is open for all. Anybody wants to comment, they can comment. Recent hard exam question may come in MOH so nothing, I mean, need to differentiate. We need to prepare well. So far, no answer out of 30 doctors. Yes, Yog Priya, you can comment.
So it could be cytomegalovirus infection.
Cytomegalovirus infection. Okay, so how did you get the idea about cytomegalovirus infection? What points favors in cytomegalovirus infection? Tell me now, one by one. So, as per Dr. Priya, cytomegalovirus infection. So, now tell me, what makes you to think of cytomegalovirus infection in this patient?
Immunosuppression. Patient is an immunosuppressant.
Okay, so patient is an immunosuppressant patient because he has already leukemia, plus he underwent for bone marrow
Bone marrow
transplantation.
transplantation.
Also, this patient has a lot of immunosuppressive agent, including steroid. And now patient has a fever because 100.6 is quite high, right? It's not small. Also, little oxygen is little less, 91%. Right? What this PP65 antigen positive means? Anyone? What is PP65 antigen? Anyone, any comment? It's a classical case of. Yes. Dr. Reshmi, any comment?
No, sir, I don't know about PP65 antigen.
Fine. So you selected valcyclovir, valganciclovir, right? Why not ganciclovir then?
Because according to my remembrance, I think that valganciclovir is a treatment of choice for CME. That's why I selected.
Fair enough. So ganciclovir is not a treatment of choice for cytomegalovirus?
Sir, the best treatment. That's what I think, but I'm not sure.
Fair enough. Fair enough. You feel that I'm not a good man. I'm asking little tricky questions.
No, sir, it's really helpful. We'll think in that way.
Absolutely. Yes, Yog Priya, you want to make any comment now? You diagnose the thing cytomegalovirus. You can give answer, no? We just discuss whatever the answer posted in the chat box. I mean, thing going.
Sir, it could be ganciclovir, sir. If its infection is not severe, then we can go for ganciclovir.
Fair enough. Fair enough. So that is the real reason you told me, right, Dr. Rashmi? Here the difference is that you both are right.
Okay.
So this is explanation. Now listen. So you get all concept clarity. This patient symptoms and X-ray finding together with PP61 antigen in serum are consistent with cytomegalovirus pneumonia, right? Because patient has a fever, patient has a cough, patient has a chest infiltrate, patient has PP65 positive. This is classical in a immunocompromised patient. So this is cytomegalovirus pneumonia, which is most commonly seen in immunocompromised patient like a bone marrow transplant. Valganciclovir is a treatment of choice for mild to moderate CMV infection and for the prophylaxis in transplant recipient at risk of infection. So this is not a mild moderate. This is already an infection. So valcyclovir or valganciclovir is the treatment of choice for which condition? Mild to moderate cases and prophylaxis in transplant for the prevention or prophylaxis, right? And the patient, however, shows finding consistent with CMV pneumonia, which is a severe infection. Obviously, pneumonia is severe. Pneumonia, hypoxia, infiltrate, transplant candidate, immunosuppression. So you can't take it that lightly or mild case, right? which is severe infection that carries a high mortality risk, making more aggressive treatment and more appropriate treatment option. And ganciclovir intravenous, possibly combined with intravenous immunoglobulin therapy, is the first line treatment for severe and life-threatening CMV infection or CMV pneumonia in patient with ganciclovir resistance. So now second question, you give ganciclovir, but patient does not respond to ganciclovir. What is the next drug of choice? Answer is foscarnet. Foscarnet. So this is a foscarnet. Foscarnet. This is foscarnet. So it is the drug of choice. So diagnosis of CMV pneumonia is confirmed. If CMV is detected, bronchoalveolar lavage, blah blah, they can be done. Anyway, so here considering the severity of the cases, ganciclovir, that is also intravenous, right? Well, ganciclovir is not available intravenous, right? It's oral. So intravenous ganciclovir is it's the drug of choice in a severe case. Mild to moderate, oral, well, ganciclovir. Is that clear? Yes or no?
Yes.
Yes, sir.
Wonderful. Which of the following test is recommended? So those who have given the wrong answer here, levofloxacin or some azithromycin, it is not a community acquired pneumonia where you need use the macrolide, right? Azithromycin and erythromycin, right? This is not a community acquired pneumonia. It's a post bone marrow transplant patient, immunocompromised, especially the CD4 counts are very less. In that case, you must use this.
Sir, is there any other condition where we will get PP65 antigen positive? This is only a condition.
Yes.
Okay, sir. Thank you.
That is why it is specifically given that PP just for the clue.
Okay. Thank you, sir.
Which of the following test is, just bear with me more 10-15 minutes, few more questions, then we'll close up. Which of the following test is recommended to be used to screen the celiac spore is suspected? So you are suspecting celiac spore. Ceiling test, anti-gliadin IgN IgG antibody, IgA tissue transglutaminase antibody, withdrawal of lactose from the diet to monitor the improvement of the system would be the best test, and Scotch tap test. Yes, Dr. Ravi. Any comment, Dr. Ravi? Can you speak it? Dr. Radhika, are you okay? Dr. Radhika.
So I think it is B, anti-gliadin Ig and IgG antibodies.
Okay, so your answer is A.
Yeah, sir.
Okay, so now let me ask you the three things as my routine things in my triad: diagnosis, investigation,
CF2.
treatment. So they have given the diagnosis celiac spore. So diagnosis is already been given. Now they are, I mean, suspected. You are suspecting celiac spore, right? So what is the another name of celiac spore? Can you tell me, another, Dr. Radhika, another name of celiac spore? There are
tropical, not getting the full name, sir. Tropical sprue.
tropical sprue or non-tropical sprue?
No, tropical.
Okay, tropical.
Non-tropical, sir. Non-tropical is true.
See, now another answer comes. So one is saying non-tropical, one is saying tropical. I know the answer.
Non-tropical sprue or celiac disease.
Okay, so these are, Radhika, just for the clarity, these all are the other name of celiac spore. One is a non-tropical sprue, another is a gluten sensitive enteropathy,
Yes.
third is a celiac disease. So many people get confused. These all are different disease. No, these all are different disease. They are all same disease. So this is non-tropical, means there must be some tropical sprue, right?
Yes.
Right. So now you are suspecting this condition. So IgA tissue transglutaminase, anti-TTG is the answer, right? So now tell me, in which condition you see the anti-gliadin Ig and Ig antibody? If I ask you the answer, my question is now different, right? You have a, sorry?
Celiac.
Okay. Then why you have not selected C, B? Then why selected C?
My option is B only. I selected B.
Okay. So this is also celiac disease, Dr. Radhika. This is also a celiac disease, Dr. Radhika, or celiac sprue.
Yes, sir. Actually, I am confused between B and C.
Select one in exam. You cannot have the liberty to select two. Anyone? Banish?
Ig tissue transglutaminase antibodies.
Okay. IgA, anti-gliadin IgA and IgG antibody.
Okay.
It's more. The transglutaminase is false negative result, I think.
Okay. So what's the answer? Half house is
So,
B and half house is C.
So B
so
is
B.
anti-gliadin antibodies.
So now, sorry to ask you. B option is seen in which condition? One question, first of all. Anti-gliadin IgA seen in which condition?
So celiac is proof like this is.
Sorry? Speak little louder, no problem.
So celiac is proves and these anti-gliadin antibodies we see this.
So everyone's homework, you go after my lecture, find out all the things. Sealing test is done for what? This anti-gliadin antibody seen in what? IgA trans TTG seen in what? What is the importance of this withdrawal and where is the scene? Scotch tap test. It's your homework. Write down, take a picture of this slide and go and read it. Can anyone tell me what is
The
the
cystic
difference between
fibrosis. Cystic fibrosis.
cystic fibrosis? Where, what see in cystic fibrosis?
I think the IgA tissue transglutaminase antibodies. I'm not sure, so either B or C. It's present in cystic fibrosis.
Fine. So homework. Do little exercise because I'm also doing a lot of exercise before presentation. So you do also do little exercise. Give me all five tomorrow. Post it in the group. Sealing test is done for what? B is done in what? C is done in what? E, F. That's it. Any
So,
volunteer wants to speak
the
about
IgA,
tropical versus non-tropical spur? Anyone? Dr. Radhika, do you know what is tropical spur? What is non-tropical spur? What is the organism and what is the mechanism or what is the pathology in tropical and non-tropical? Banish, Dr. Banish, are you there?
Yes, sir. Yes, sir.
Any comment on tropical versus non-tropical?
Sir, I have not studied this, right?
Fair enough. Fair enough.
Yes.
Fair enough. So this is head-to-head comparison. Very important. Take a picture or later on you can see the
Yes.
video from YouTube channel. So etiology is celiac disease, right? So celiac disease, as we discussed, right? So what is that? So it's a immune mediated. This is not tropical. This is non-tropical. Celiac is a non-tropical, and this is tropical, tropical part, tropical country, tropical region, right? So this tropical is usually infection, and this is autoimmune. So immune mediated disease, right? And when there is an immune mediated disease, you must see there is a antibody, right? So this is immune mediated. Number one, family history here, yes, it is immune mediated. So there is family history here, no family history. There is a history of traveling to the tropical region. That's it, right? Another thing is here autoimmune. Most of the autoimmune occurs in female. There is no male female measure these things, right? Endomysial or endomysial or tissue transglutaminase antibody. So answer C is correct. It is present. This is absent. Iron deficiency absolutely common. It is not common. Severe folic acid is here more common, and intestinal involvement proximal in celiac disease more common. Here proximal plus distal. So basic important thing between celiac and tropical or non-tropical and tropical is it is immune mediated, more in female, right? This is high yield point. This because of it is a immune mediated, so there must be some antibody, that is anti-TTA is present. That's it. This is what the high yield point. So this is not given in any book. It is not in the MTB, right? I usually do some research before presenting my lecture. So I got this interesting for the better clarity how you differentiate tropical from non-tropical, and non-tropical is a celiac disease, right? So what is the here the answer? IgA tissue transglutaminase antibody or anti-TTG, right, is the test of the choice, right? And here I get a summary. Excellent. Celiac disease, also referred as a celiac spur or non-tropical spur, is a common condition characterized by maladaptive immune response to a gluten, and that is why it is called gluten sensitive enteropathy, right? So if you have a gluten diet, you take a gluten diet, right? It will precipitate the GI symptoms. So they lifelong usually have gluten-free diet. That is the most important treatment of this. So diseases often occur in patient with other autoimmune illness as well, right? And the underlying pathophysiology is believed to be a gluten intolerance or triggered by the gluten. Typical finding in school in the malabsorption, right? Absorption of iron, B12, folate, also fatigue, weight loss, vitamin deficiency. Diagnostic tests include the detection of the various antibodies. One of them is anti-TTG. To confirm the diagnosis, endoscopic biopsy of the small intestine or proximal intestine is also needed. Histological finding often includes atrophy or crypt hypoplasia, and definitive diagnosis is necessary as the therapy involves a lifelong commitment to gluten-free diet. So you cannot just, make a casual diagnosis. You need to 100% confirm that this is a celiac disease or gluten sensitive this enteropathy, right? Because you need to have a commitment of lifelong B12 free diet, and prognosis is generally very good, right? And it also increases the risk of malignancy like intestinal lymphoma.
Ah,
That's it. So this is non-tropical, and what is tropical then? So this present in the same way as celiac, but it's non-tropical spot. There will be a history of the patients being in the tropic, as I told you, and serology is negative. Is a negative. No NTT G antibody. Most commonly in tropical, there is a microorganism or infection. That was non-tropical was autoimmune. This is infection. An infection can be treated with the antibiotics or doxycycline or sulfamethoxazole, and trimethoprim is the drug of choice. So this is the tropical versus non-tropical spot. So last questions for today. A patient treated for schizophrenia developed drooling, dizziness, muscle rigidity. Which of the most common drug to cause these symptoms? Clozapine, olanzapine, sertraline, amitriptyline, blah blah, long list. After this, somebody can guide me how you differentiate psychotic versus atypical versus typical psychotic drug. First, post your answer. Yes, Dr. Anitha, any answer? Answer please in the chat box. So far, no answer. Just click on what is the answer. iPhone A. Yes, anyone, any volunteer? Dr. Javed Qureshi, your comment. Dr. Nisalal, your comment.
Sorry, sir, I'm in the OPD. Sorry.
No worries.
It's close up in, I think.
Fine, fair enough. Let's see. Priya, see you.
Yes, sir.
What's your answer?
It's B. Olanzapine.
Olanzapine. Why not A?
It goes clozapine goes dry mouth, I think.
Fine.
No
Anyone?
idea, sir.
No problem. Dr. Jabahar. Anyone wants to comment typical versus atypical antipsychotic drug, how you differentiate? What are the name of the drug, Dr. Banish? How you
Sertraline and
differentiate?
amitriptyline are not used for schizophrenia. So it's between A and B.
Okay.
Either clozapine or
Antipsychotics, so they are primarily used for schizophrenia, and atypical are used for mood disorders also, and autism also, like childhood disorders also. And the examples of typical antipsychotics are haloperidol, chlorpromazine, and the examples of atypical are ziprasidone, clozapine, risperidone.
Great, wonderful. So which one is better? I mean, when you have any patients, which drug you prefer to use in your patients? Typical, atypical?
Sir,
Why then what?
typical will block D2 receptors, and atypical will block D2 and 5-HT2A receptors. So,
Okay,
sir,
so this
atypical are better because they will reduce both positive and negative symptoms.
okay. So which one has more side effect? Typical or atypical? Or both?
Sir, atypical causes weight gain and diabetes.
So that is not a good drug. Those patients who are
Yes, sir.
already obese and diabetic, right? So
Yes, sir. But then,
absolutely, yes,
typical can cause tremors and
true. That's it.
restlessness.
So yeah, so first of all, let's see what is typical, because we read for years and years typical, atypical, but we don't know how you differentiate, right? So typical and atypical neuroleptic drugs, right? So first generation, second generation is atypical. First generation is, as rightly told properly by Dr. Banish, phenothiazine and bupropion blocks D2 receptor. Here D2 and 5-HT reduce positive symptoms. Here positive and negative. So those who don't know what is positive symptoms and what is negative symptoms, go and read it, right? And these are the drug, right? First generation typical antipsychotic and atypical antipsychotic. So typical antipsychotic is a mechanism of action of first generation or typical, primarily block the D2 receptor. D2 plus is 5-H2. Example haloperidol and chlorpromazine, she rightly correctly told. And These are the second generation or atypical is aripiprazole, olanzapine, clozapine, risperidone, quetiapine. All drug has that little different side effects, but in general, right? Second generation or atypical can cause more metabolic abnormalities like glucose elevation, dyslipidemia, and weight gain or metabolic syndrome you can cause second. So those patients have a very poor control of glucose. They are very extremely obese, very bad liver functions or lipid functions. It is not a good drug, right? Or you need to select the drug which is absolutely very less toxic to this all things, right? So this is a list of typical versus atypical. So for the answer purpose, clozapine is the answer. Clozapine associated with neutropenia, low neutrophil count, absence of granulocyte, again neutrophil, so it can associated with agranulocytosis, hypersalivations of clozapine, and it also can cause orthostatic hypotension. So these are the very common side effects of clozapine. So they are very repeatedly asking in exam side effect of clozapine. So you don't need to just remember clozapine, but you need to know in general the psychotic versus antipsychotic. They ask you the indication where you use, and they ask usually in antipsychotic drug the side effects. So this is related with the side effects. So that's all from my side. Thank you very much. We have more questions to discuss. It's been more than 90 minutes now. So we'll stop it here and we'll catch you with the next mock test. Before I finish my class, I want to have little quick feedback from the audience, how they enjoy the class.
So it was a
Anyone?
very helpful session. Thank you so much, sir.
Thank you very much.
Thank you, sir. Good session.
Yeah,
Yes.
very informative session, sir. Need every day.
That
The
you told
sessions are
last.
very informative,
It's a
and
need
you
every
have
day.
made the pathway for the extrinsic intrinsic pathway very easy to
Yes, sir.
remember. Thank you, sir. Because
Yes,
that was
Wonderful.
one of the main complicated things for me.
Now it's
it is
easy
very
for
easy
you.
to remember. Yes, it's very
Yes,
easy now.
yes, it is very much.
Great, wonderful. So thank you very much all for your kind attention. We'll see you in the next lecture. Thank you very much. Enjoy
Thank
your
you.
Sunday.
Thank you, sir. Thank you very much,
Thank you,
sir.
sir.
Good day. Thank you, sir.
Thank
Good
you.
day. Bye.
Appreciate. Thank you.